everyone, to another installment of the Cal Voices Access Program podcast series. My name is Claire Courtwright. I am the advocacy director for Cal Voices and the content creator of the Access Program. And with me today for this podcast is Dawniell Zavala, and I'm going to let her introduce herself.
Hey everyone, I am Dawniell Zavala. I am the Associate Director and General Counsel here at Cal Voices, and I founded the Access California program back in 2017. And I'm hanging out with Claire today to talk to you all about behavioral health transformation, changes to the Mental Health Services Act brought about by Proposition 1 last year, and what that means to you on the ground. So, yeah.
Awesome. So I guess I'll start by saying a lot has happened since the last time that we did one of these podcasts. In the last couple of months, some pretty big changes to what the administration calls behavioral health transformation been put in place. They primarily relate to Medi-Cal, but just to kind of give folks an overview, the administration refers to a whole bunch of different initiatives, really a very large number, as behavioral health transformation. So we're talking the expanding criminal and civil court systems that order people into treatment for mental illness and substance use disorders, as well as Proposition 1 that is building a large number of treatment facilities, and changed the Mental Health Services Act to the Behavioral Health Services Act. And then also most recently, really at the end of December, some changes to Medi-Cal in California that also affect these dollars and affect these systems. So that's like kind of the big picture of what's going on. And we're going to go through a little bit of kind of the technicals around that to say, to really address like how this is affecting peers, how it's affecting people with serious mental illness who are both, clients and consumers in the public behavioral health system. We're service providers, we're community-based organizations, we receive services, and all of this is really starting to, the rubber's starting to meet the road. Things are starting to change as a result of Prop 1. So we're going to kind of catch you up with like what's current there.
And I'm going to play the role of sort of the layperson because, in a way, not in a way, in many ways, a lot more than I do about the technical ins and outs of this. And so I might ask questions that are sort of getting to what the average person might want to know about what this means for them. Is that cool with you?
Yes. Yes, my neurodivergence has to be retranslated and channeled back into human speak. So this is true. This is true. We're like wonk out, and then you'll be like, "What are you even talking about? How does this affect real people? Like, why is this relevant?" So thank you. Please do perform that function. Help me cope with my mental illness. So I will say the current issues that are really affecting like peer run organizations, consumer operated organizations. So those are community based organizations run by and for people with mental illness. They're seeing a big impact from Prop 1 right now. People that receive services in the public behavioral health system, are going to start seeing impacts. Hopefully they will be notified by their counties and their plans that their services are going to significantly change and what those changes will be and whether they can affect how that goes in the community planning process that's coming up. But as I said, the rubber is starting to meet the road. So this is kind of technical, but it's sort of the why to explain what's happening because we're getting a lot of questions from community-based organizations, from consumer-operated services, from clients and consumers saying like, our counties are telling us this, or I'm hearing this, what's going on? So this is really kind of like what's going on. Something is going on. So I just want to like zoom through kind of like a review of like what has changed in the law that is now starting to be implemented on the ground. So the Prop 1 changes the Mental Health Services Act to the Behavioral Health Services Act, and that really changes two things. It reduced the amount of money that was available to the counties for what we think of as services, in favor of putting some money into housing. And it also changed the permissions that the counties have to spend dollars in a certain way. And so we'll just call that money, change the money, and it changed the discretion, it changed the permission. And so that like really creates big changes for the system. Um, with respect to money, if your county wants to, pay for milk and cheese and butter, the law has to say that the county is allowed to use these dollars to buy dairy products. So that's called affirmative authorization. It just means you have permission to fund the kind of thing that you want to fund. Um, and there has to be money, right? There has to be enough money to do the thing that you want to do. And then the other thing is, the more dollars that we use for sort of traditional mental health treatments like psychiatry or psychology or social rehabilitation, learn a skill, learn a life skill, learn a job skill. When we're funding those kind of traditional things, it crowds out the ability to fund the non-traditional things. And a lot of what the peer movement is about, a lot of what consumers and clients want, is more than the traditional system that doesn't serve us well. So that's the money aspect of it. So Prop 1, it removed a lot of money out of the services bucket. And it also created a lot of new um, directions from the states to county on what they had to do with money. And, again, like, so what are these some of like non-traditional things that we're funding with this money that could go away in favor of the traditional medical model treatments? Like, so for instance, Sacramento County has a program that funds a summer camp where adoptive parents of children with serious mental illness can send their adopted children for respite care. Those kinds of things are not paid for typically out of health insurance, out of Medi-Cal. And so, when we see money flowing into like the traditional medical model idea of mental health treatment, it deprives money from the non-traditional stuff that can't be funded through health insurance. So that's like one of the big changes that's going on. Um, and so, again, money and discretion, like money and permission. So it has to say somewhere in the law that you can spend money on a certain thing or you can't do it. So you need the authorization. And that has to exist either in the law or they make up a rule after the fact called a regulation. It has to say there. So I gave the example like milk, butter, and cheese. If you want your county to be able to spend on milk, butter, and cheese, the county has to have permission to spend on dairy products in the law or in the regulations. And then another big change from Prop 1 is like, we're telling you to use most of this money for the traditional system, for the medical model. You have a mandate to do that. And the reason you have a mandate to do that is because the federal government will kick in half. So it's about stretching dollars. So that's kind of what's going on with these big picture changes that are affecting folks right now. And again, on the, this is a graphic that I like because it shows what happened with the money. So on the left is the Mental Health Services Act. Basically, all of those dollars are going to services. There was some housing mixed in there. And then on the right is what happened with the Behavioral Health Services Act. All that purple, that came out of services funding and it went into housing. The yellow band in the middle is full service partnerships that stayed basically the same. And then the blue at the bottom, that's where the big funding cuts happened in Prop 1. So it not only sort of shuffled money around, it also took some off the top to the state. And like the result of this is kind of complicated. So I'll just kind of show people like we didn't just move a bunch of purple money into the purple in housing that can't be used for services. We also shuffled around all the categories of the things on the left and made it really complicated where cuts were going to happen. Everybody wants to know what's going to get cut. So this is why it's really complicated. What they did is not just that they sent more money off the top to the state, which they did. So the counties have less money overall. They then restricted a bunch of the money to housing, and the remaining categories of funding got all shuffled. And this looks like modern art. It's very complicated what happened, but the kind of take home message is that um, of the things that were funded out of the Mental Health Services Act and are currently funded out of the Mental Health Services Act, the way that they shifted around dollars means that certain parts of the Mental Health Services Act took a bigger funding hit than other parts. So the MHSA always paid for housing. money was moved more into that end of the system. So you saw a lot of money now being dedicated to being spent on housing interventions. Full service partnerships, that was always a major component of the MHSA, and by some magical math, there's more money there. But other parts of the MHSA, like prevention and early intervention, that lost money. That money primarily went up to the state out of PEI. And then the thing that took the biggest whacking hit was community services and supports in the MHSA, that is now called Behavioral Health Services Act, BHSS, Behavioral Health Services and Supports. That took a major hit. So this is like very ballparked because of the complication of these funding changes. But basically, if you're saying I got $2 billion a year, like how did it shift around? You're seeing about a $700 million hit out of community services and supports.
So, Claire, really quickly. So,
Mhm.
as I'm looking at this, I'm seeing it. I love the way that you lay this out because you can really see sort of like what is getting prioritized and what's getting deprioritized
Yeah.
in how they made these funding shifts. And so, as I'm looking at it, I'm seeing that the state is really prioritizing housing interventions, which I'm sure you'll talk about what those are, right?
Hmm.
um, and also full service partnerships,
Hmm.
and not so much with early intervention and not so much with community services and supports or behavioral health services and supports, which traditionally under the Mental Health Services Act, where all the types of things. So I don't know if you all remember, if you've been around for a while, but the Mental Health Services Act was supposed to provide whatever it takes, right? Whatever it takes to help folks with serious mental illness get well and stay well. And so it funded out of community services and supports all of those non-traditional types of services that you were talking about or referring to earlier,
Right.
things that were not necessarily Medi-Cal billable.
Right.
And so what I'm seeing here is that there is a trend to more intensive services, more potentially inpatient or services, or more acute level of services, as if we're talking about full service partnerships, and then some sort of sheltering options.
Yeah, exactly. And we'll go like that's a good segue because we're going to talk a little bit more about that. But you're correct. You can see the state prioritizing certain things, right? We're prioritizing housing, which we desperately need housing, but we would have appreciated more money, not just shifting around money that we had and robbing Peter to pay Paul,
Mhm.
which is kind of what happened here. Full service partnerships have always been a major part of the MHSA. They were a dedicated, significant part. About half of community services and supports were dedicated to full service partnerships. And, it's complicated what happened with that there, too, because some counties actually have to cut their full service partnerships because of Prop 1. Complicated reason for that. But you're right. Overall, the trend is like what is getting defunded is alternatives to traditional treatment, upstream preventative and early intervention services, and the for us, by us stuff, right? The stuff that the community demanded and created out of whole cloth that was never a thought in the mind of the people who make health insurance. That's the stuff that's really on the chopping block. And so, like we're talking about, not everything in the MHSA took the same hit, right? So there's still a fair amount of money in early intervention that's fairly comparable to what it was, although the state has also kind of changed what that means. But the thing that really took a big hit is a part of the MHSA called Community Services and Supports General System Development. And so, like, what is that? This is what's there, right? This is what has taken the biggest hit just in the statute. Um, from this pot of money, you're seeing the explicit permission, that discretion that you need to fund alternative and culturally specific treatments, peer support, our wellness and recovery centers, um, crisis intervention and stabilization services. So we have like drop-in centers, warm lines, um, and there's other stuff in this category, but people do real work with it, develop and implement strategies for reducing ethnic and racial disparities. People are doing real work with this money. So that is the part of all of this that has taken the biggest kind of shellacking in the way that the funding was shuffled around. And even that part of it was replaced with, this reference to a bunch of stuff that's really Medi-Cal.
Mhm.
And so, I mean, we've asked people outright, or we've asked the state outright, like, hey, everybody wants to know, like, what is most at risk? It is actually this. People will say, well, we don't know yet. We're not sure how much money. Not true. I mean, in terms of like what's in the law, they completely replaced the general services development category with something else. It's not even clear we have the permission to fund these things anymore. And then in terms of how they shuffle money around, what took the biggest hit? It is this category took the biggest hit, financially. And I think if I go back and show that graphic on what took the biggest hit, it's this, right?
Mhm.
So that community services and supports general system development used to be part of this 38. It was the majority of this 38. It's down to 17.1. So that's about half. But when you also factor in, because this stack should be shorter because some money also went to the state. So you're looking at going from about 38 to about 16%. So you're talking about a 57% funding cut in concentrated there. So, you know, that's a problem for the
S-
community.
So let me ask you this. So when you were going through the regs, the MHSA regs, and you cited that one regulation where it said that general system development funds could also be used for project-based housing.
Yeah.
Do you think the state would say, I mean, I'm just sort of like trying to tease out like what the state might respond and say that, well, yes, we got rid of general system development, but we replaced the project-based housing with the housing interventions. And so all of that money didn't really go away. It just got redefined.
Well, I mean, let's go back to this graphic, right?
Mhm.
Trying to follow the money in this graphic is really difficult. And I think when we've had conversations with the state and we said, tell us exactly, or with counties and said, tell us exactly, like, follow the money and tell us exactly where the money moved and where you have more and where you have left. They say it's too complicated to tell us. I'm sorry, that's a real response.
Okay,
I'm keeping it real.
got it.
So it is very difficult to track. So you do have to kind of use these broad overview uh, reliable things. So this is reliably in the law. It is absolutely true that that funding category dwindled the most out of
Mhm.
anything.
Mhm.
No one disagrees with that. It's true that GSD is not, general systems development is not now called out specifically in the law saying you can fund wellness centers, you can fund peer support, you can fund culturally specific and alternative treatments, you can fund drop-in centers, you can fund warm lines, local suicide prevention lines that are fully non-police response and for specific subpopulations like LGBTQ, right? I mean, we're not seeing, like, the money took a big hit, the discretion is not there. A coalition of us have asked the state to put that back in, put it in your regulations, say you can still fund these things, but people are fighting for this stuff right now is kind of the point. And for people that really want to nerd out, that's the only thing that's really missing. When we tracked, the MHSA versus the BHSA, are all of the permissions still there in the BHSA that were in the MHSA to fund different kinds of things? It's all there, at least in name, except for this one subcomponent. And that's starting to like really play out for the community.
So I have another thing occurred to me, and I would like to hear your thoughts on this. So, although the community services and supports category of the MHSA previously also contained the FSP. A portion of that was for full service partnerships, and then the rest was for general system development and a few other things, right?
Mhm.
Um, But I'm wondering if what the state might say is that, okay, well, we basically preserved all of the funding for FSP for the most part, right? It
Mhm.
took a smaller hit,
Mhm.
I think. And like you said, some places it might be bigger or smaller, but
Right.
overall, it seems like the pot for FSP might have increased.
Right.
And then they have like, the housing interventions, which may or may not take care of the project-based housing component in general system development. Um, I'm wondering if the state might say, well, we can get away with less funding in behavioral health services and supports because with the mandate to maximize and leverage Medi-Cal, we're actually going to be spending more money on services, which you're probably going to get into a little bit when you talk about BH Connect. But I'm
Yeah.
thinking like, sort of, how are they selling this without? Because if you just look at the numbers, it like straight up, it looks like just cuts, 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 and that's, I think, what the community is probably, at least initially, that's what the community might be
Right.
experiencing. But I'm thinking that the state may come back and say, well, actually, even though there's less money allocated to it, that money can stretch further. And so you're really
Right.
technically going to be getting more services out of it.
Right. And your part of this conversation was not to be a wonk. And you have failed. You failed.
I'm sorry. I'm
You've
sorry.
completely failed in your mission,
I have.
but everything you said is absolutely segues and is important. And I think I have some graphics to like, you know, between legal citations to talk about it.
All right.
But
I haven't seen all these slides, so I'm just like thinking of these things on the fly. And you
okay.
probably are covering all of
All
them.
right.
So,
Well, we'll go back then and use this graphic so people can walk out with us. So you're right. So, right, this is all like the purple, that is paying for rent to keep the lights on, housing navigation, housing sustaining services. That is not for a peer support worker, an IHSS worker to come to your home and you know, be with you and help you manage something. This is rent, you know, it's buildings, that's utilities.
mhm.
The yellow, full service partnerships, although that you can see that's the light blue on the left to the yellow. It's about the same size. But what the state has designed to make up for these cuts is expanding Medi-Cal services and putting them into the places where they can bring in another federal dollar. So I think when we were talking about this before, it's like, well, you know, if you want to serve steak and your health insurance doesn't cover steak, then you have to pay 100% of the cost of steak yourself. But if you're willing to serve something your health insurance will cover, like chicken, then they're going to pay for half of the chicken.
Mhm.
So if you don't have health insurance, you have no coverage, you're paying 100% for a steak. But if you are willing to serve something that health insurance covers, you can have two pieces of chicken. So what the state has done in the full service partnerships, in early intervention, and less so in BHSS, is create a bunch of new Medi-Cal services, new coverages that they can pair with these dollars to try to make those pieces of the pie fatter by bringing in a federal dollar.
All right.
But for the stuff that you cannot bill Medi-Cal for, there's no vehicle to do that, right? So like that's a big part of the controversy that's going on right now, and I'll skip and we'll come back to it. But that, you're right, right? So it was double your money in the yellow. It's maybe double your money in the first two light blue bands, but in the bottom band, you're not doubling your money. You know, do you end up then with some pretty steep cuts? It's looking that way.
Got it.
Okay. So that was a good segue
Yeah.
because you
I'm
had
psychic.
you had no idea this slide was coming, and it's, you know, very basic. So I'm sure it's
Well, it's
engaging for
literally
people.
my level of understanding of this at this point. So,
Yeah, so this is what happened, right? So California asked the federal government, hey, can we cover some things under our Medi-Cal plan for people with serious mental illness and substance use disorders? Um, you know, can we expand what's covered in insurance so that we can bring in a 50, you know, 50 cents on the dollar from the federal government, or double your money if we do certain things with our BHSA dollars in our full service partnerships? So the answer was yes. And that yes was like, it was even after the election. I think it was almost the end of December when the federal government said yes. And so what we're looking at is that full service partnerships are going to be mandated to offer assertive community treatment, forensic assertive community treatment, supported employment, clubhouses, enhanced community health worker services in these full service partnerships. That's the vehicle to make that slice of pie fatter without the government, without the California state government putting more money into it. So this is what they call leveraging and maximizing Medi-Cal. They're like, we're going to leverage and maximize Medi-Cal with BHSA dollars. It's a command in the law to do that. So that's what they mean. They mean that we're going to take these Behavioral Health Services Act dollars and we're going to use them for insurance coverages to bring in more money from the federal government and really make up for some of the cuts, because we're bringing more and more people into the systems and there was no more money. So this is how you bring in more money. But again, it goes back to that issue of, are the things that we need things that insurance covers? If we still need them and insurance doesn't cover them, what then? Right?
Mhm.
So every dollar that you spend inside of health insurance doing things that health insurance will pay for, is a dollar you can't spend doing things that health insurance won't pay for. Health insurance will not pay for the summer camp for children with serious mental illness, and respite for their adoptive families. So that's kind of what's at stake here. Um, and now, that was a lot of blah, 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 blah about technicals and money shifting around and Medi-Cal and what's not Medi-Cal. And people say, well, is this really hitting the streets? Is this really having an impact? And someone sent me this article from a couple of days ago, from March 3rd, from the Marin Independent Journal, about what's happening in Marin County, that kind of illustrates everything that we just talked about. So, first of all, like the Behavioral Health Services Act siloed, 30% of funding to housing, taking it out of services. So you can see that most notably, BHSA shifts 30% of the MHSA funding from mental health services to housing, right? And this is going to result in fewer dollars to be spread around. So you are looking at a net loss of money to counties. So Marin says it's facing a reduction of $12 million in state funding for mental health programs because of Prop 1. Um, and you can see, all right, when you shifted this money into housing, and we have the losses from shifting into housing concentrated in certain places, where are you seeing that show up? Um, the programs at risk of lower funding include what? Peer run drop-in centers, jail diversion programs, family support services, crisis residential and hospital diversion, community health advocate programs, field-based access staff, and behavioral health infrastructure and staffing. Um, so some of that stuff is exactly what we're talking about. A peer run drop-in center is not a traditional Medi-Cal billable service. That's the kind of thing that's stake. You have to pay for stake cash because your health insurance doesn't cover it. So, and you can see more this is really a very good story to illustrate what's happening. It's like, why are these alternative kinds of services like a peer drop-in center? Health insurance just doesn't recognize that, a brick and mortar location that doesn't involve a psychiatrist or a psychologist or an LCSW, that isn't offering medication management or therapy, that is a community center run by and for people with serious mental illness. That is not something that is viewed as valuable by the health insurance system. Although it is incredibly valuable because it's for us, by us, we're choosing to use it. We do use it. We're choosing to work there. We find that it meets a need. But because we're not inside that Medi-Cal box, inside that health insurance box, that is creating problems. And so one of the problems is, like, we're talking about a peer drop-in center. It's a 9-person staff. It doesn't have any clinicians. It's not able to really bill Medi-Cal easily. And you see that even before the BHSA funding shifts take effect, this program lost $30,000. And there's programs that can't lose $30,000 and keep doing everything that they're doing. So now they're like, well, we're going to try to bill Medi-Cal wherever we can. And because we're required to try to take advantage of Medi-Cal wherever possible. So this is what the supervisor is talking about in Marin County. And she's also talking about, one of the money off the top to the state that's affecting the pictures. It's a net loss of $1 million to Marin County in prevention and early intervention, because the state took over population-based prevention. So, there are funding threats that are significant for counties, and they're significant for the people who use these services and choose to use these services. And you can see how the system is rebalancing too, because with the other initiatives, not just Prop 1, not just changes to the Mental Health Services Act, but also because the counties are required to stand up these involuntary programs like Care Court that cost money, and they didn't get any money from the state to do it. And so you can see the sum total result is what we're talking about, right? It's a system that's rebalancing in a certain way away from the away from the original Mental Health Services Act that was written and passed by people with serious mental illness for people with serious mental illness to do a specific kind of work like peer respite, peer drop-in centers, wellness and recovery centers, warm lines, culturally specific and alternative treatments, respite, all of this stuff, respite for adoptive families, all of this body of work that was voted into law, bypassed the legislature. People got signatures. People stood outside Safeway and got signatures to put this on this ballot, get this money, and do this work. And you're seeing the system really take that back into Medi-Cal, into health insurance coverage, into a mentality about what we need that was designed without us. And maybe doesn't meet our needs. And we're also seeing these systems rebalance in favor of new and involuntary expanding court systems at the same time. And we're looking at, at least right now for Marin County, this is a net loss, right? It's a net loss in funding.
Yeah, and I just want to say, so as you know, I've worked here for it'll be 13 years formally that I've been an employee of Cal Voices in June, and we're a small community-based organization that does really good work, and our people are very, knowledgeable and dedicated, and they have a lot of institutional knowledge around peer support services, around the public behavioral health system. And one of the things that is concerning, as this story uh, illustrates, is that small local CBOs, not only are they at risk of harm from the overall funding cuts, but even if they shift to billing Medi-Cal, oftentimes that is they don't have the volume in order to actually bring in enough funding to maintain the types of
Right.
services that they previously provided under the MHSA. And so, so even if the state is saying like, okay, well, we cut this funding here, but we can make it up by offering more, more chicken, basically, right? But the problem is that I don't have capacity to serve 30,000 plates of chicken, right?
Right.
And the only way I can stay open is if I serve 30,000 plates of chicken. And so what ends up happening is a lot of these community-based organizations, the work that they did and the specific knowledge of their populations and their unique communities, in Marin or in Los Angeles or in Modoc or, anywhere throughout the state, a lot of those organizations are going to have a difficult time remaining open, and they can't. It's not so easy to just shift to billing Medi-Cal, because even if they could, okay, there's issues around site certification, and then getting electronic health records, which is a upfront expense, and then perhaps having to keep a clinician on staff. They are not going to get the same volume that a major healthcare provider will get in order to remain in business.
Yeah, I think I mean, yeah, it's some people will follow all of that, some won't, but it basically there's
So I failed at my job again.
well, now I'm helping you. Just sharing is caring. But I mean, yeah, so I mean, what's the take home message from what you just said? Um, Changing the business model um, is very difficult for small organizations, and these policy shifts and these legal shifts favor large organizations. It's much harder to keep a 10 bed pure respite non-medical billable facility open than it is for a 150 bed hedge fund owned acute psychiatric hospital.
Yeah, where they can kind of spread out the losses and the risk amongst all the various facilities and like people that they're serving.
Yeah. And yeah. So, I mean, I think the attitude of a lot of people is kind of like, well, just be, just sort of morph into this other kind of entity. And it's like, that's actually like pretty infeasible for a lot of our
Right.
community-based organizations.
Right.
Um, Yeah, so this is the last part of the story and kind of illustrates the cost pressures on the counties from unfunded mandates. So, they're like, there's a potential $12 million shortfall created by Prop 1, and a $2.3 million bill to spend on mobile crisis and care court in the next year. So there's just a lot going on with these policy shifts. It's the rubber is starting to hit the road, like I said, and people are starting to be able to tabulate these very complicated policies and funding shifts and go, wait a second, like this is what this is going to look like.